Good evening. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center in Des Moines and founder of Above and Beyond Cancer. Welcome to our Cancer Education Series. This event is sponsored by Mercy Cancer Center and Above and Beyond Cancer, and it's brought to you in part by a grant from the Iowa Cancer Consortium. And tonight, also a sponsor of our event is American Cancer Society Cancer Action Network. And I have two guests with me tonight. So let me introduce to you, first of all, Senator Liz Mathis. Senator Mathis has been in the Iowa Senate since 2011 and has played an important role in public policy, especially as it relates to health. And we're going to talk to her a bit about her career, some of the seminal legislation that she's been involved in, and also talk about how we, just regular citizens, can also play a role for advocating for public health policy. Senator Mathis, welcome.
Thank you. Thank you, Doctor.
And after Senator Mathis and I have a conversation about advocacy and public policy related to health and cancer, we'll be having a conversation with Ashley Ezzio. And Ashley works for the Iowa Department of Public Health, and she helps oversee a very important program, actually two programs, the Breast and Cervical Cancer Early Detection Program and the Breast and Cervical Cancer Treatment Program. This year marks the 30th anniversary nationally of the Breast and Cervical Early Detection Program. And we're going to talk about how that program developed, how it came to be, and specifically how it works here in Iowa. So thank you, Ashley.
Thanks, Dr. Deming. Happy to be here.
So Ashley, I think I'll have you go off for just a second, and Senator Mathis and I are gonna have the conversation. So Senator Mathis, we've had the opportunity to chat up at the state capitol. I'm a volunteer for the American Cancer Society Cancer Action Network, which is the advocacy arm of the American Cancer Society. We come up to the state capitol every year with cancer survivors and other advocates and meet with our legislators and help advocate for public policy. As you know, Senator, I'm a cancer doctor, so one patient at a time throughout the year, I get to make a difference in the fight against cancer. But as a volunteer with the American Cancer Society Cancer Action Network, I get to advocate and help influence public policy that can affect millions through public policy. And that's what we're going to talk about is public policy, kind of with a capital P. Maybe give us a little bit of background. I know you grew up, I think, on a farm, and at least yes, in rural Iowa, and have a background in journalism. Tell us a little bit about yourself, and then specifically how you decided to run for the Senate.
Well, my mother actually went through the World War II Cadet Corps to become a nurse. So she was a teacher in a one-room schoolhouse. And then she went through the Cadet Corps to become a nurse. And when World War II ended, she was the town doctor's nurse. And so not only did she mend broken bones and deliver babies, and an occasional chicken for payment would come in, but she also, doctored us very well. So my sister became a nurse, and then when I was married, my mother-in-law was the director of nursing at UIHC for 27 years. My brother-in-law is a doctor. My sister-in-law is a nurse. So we have a health family. We believe in science and we believe in health. And so I was kind of raised that way and have continued throughout my life to do that. I worked for a nonprofit for about 13 years at Four Oaks. And so a lot of kids were treated with mental health issues and also related medical issues. So I've stayed in that vein. As a reporter, I covered hundreds of healthcare stories. And primarily, we used to do series around breast cancer research and how research was changing, and the types of doctors that were involved in, promoting that research and promoting good care and regular exams for women. So we tried to get that out as much as we could through journalism, and the series that I did were with KWWL in Waterloo, and then also with KCRG. So healthcare is in my blood, and when I got to the state senate, I thought it was a natural progression that I would sign up for policy for, it's called human resources policy, but it's actually health and human services. And so I've served on that committee for as long as I've been in the state senate. First, I came in as a member of the committee, and then I was elected chair of the committee when we were in the majority. And now I'm ranking member now that I'm in the minority. So I'm still on the committee. And some people say you drew the short straw, and I say, oh, that's not true. It's the most important committee, I think, at the state capitol.
And Senator, was there a particular issue that motivated you to run?
Yeah, there were a couple of different issues. As I was working at Four Oaks, and I was an advocate going to the state capitol, I went to an appropriations meeting, and I heard legislators talk about adult mental health for about an hour and a half, and then children's mental health for about 10 minutes at the end of the meeting. And I thought, wow, this needs to be turned around. There's something here. If we invest in our children, we would hope that their mental health would be managed by the time they're adults, or at least they would be able to know how they could resource that health. That was one of the things. Another thing is that I cared for my aging parents. My father had heart failure, and my mother had Parkinson's. So when my father died, I was tasked with taking care of my mother, and then she went into skilled nursing. So I got to really see how, the healthcare process as a daughter, as part of the sandwich generation. So taking care of my parents and taking care of my kids. And so, was very involved in both of their healthcare as they were getting older, and got to see, the issue around medications, the issue around payment. As my mother's healthcare declined, she was in skilled nursing. It was very expensive. And just how I was able to help her manage her budget and manage, her assets so that she could at least get some good health care. She was very lucky to be able to do that. But that's what really motivated me. I think two of the healthcare reasons to motivate me. And the other was that, there were several other issues that I thought I should run and run for a special election. It was to save the 26th seat of the Democratic majority. And so I ran, and we won, and we held the majority for several years after that. So we were able to pass a lot of good healthcare policy then.
Great. Well, thanks for that background. Let's talk a little bit about how laws get passed, how legislation gets written, how issues sort of get looked at as a problem, and then how bills get go through the system as a solution. So, for example, cancer. Everybody's against cancer. Everybody is for good cancer control. So it's not a partisan issue. Sometimes it gets a bit partisan when it comes down to how certain bills are going to get paid for and those sorts of things. So maybe use cancer in terms of either tobacco control or access to care. Maybe frame a particular issue that resulted in legislation, and tell us kind of how that legislation sort of percolates up, and what takes place as it goes through the process to actually turn into legislation that affects health policy.
Well, bills come to us, or I should say policy comes to us in a number of different ways. So one individual can call me and say, there's an issue here where around my breast cancer exam or payment for it, or they could bring something that's problematic to us to be able to be problem solvers for them. And sometimes when I sit down with an individual, and I find out that it's not only that person, but very many people that are affected by the same thing. And so that sets policy in motion. Then I do a lot of research. I ask our Senate staff to get involved in it. We talk with IDPH, or we talk with DHS, and we find out if there are any remedies within the system or any resources that people can use. So we try to first find those resources that might help solve the problem. And if it isn't anything like that, then we have to fix it, and we have to fix it via policy. So it could be one individual that comes to me, or it could be a group of advocates, such as yourself, Dr. Deming, or it could even be someone who has had something happen to them. So I'm thinking of one piece of legislation within the last 5 years. There was a woman who had dense breast tissue, and she started to realize that not everyone was told that they had dense breast tissue, and perhaps they needed more imaging, or they needed further tests, and that she felt that their x-rays or their exam should probably be flagged that you have dense breast tissue, and you might consider getting another x-ray or another step up in your exam. And so she came to the state capitol with a group of women who had the same issue. And some did go on to get some imaging done, and others did not. And the ones that did not felt like they couldn't afford it because it wasn't paid by insurance. So that was the issue. It was not only checking on a report that, the exam showed they had dense breast tissue by the radiologist. And then again, the treatment after that, being able to take that imaging, to another level and have that paid for by insurance, either commercial or Medicaid. And so that was the issue. Bridget.
Yeah, if I might add, Senator, just and I'll let you go on with the story, but that's the Army of Pink, and I think you're going to talk about the
Yes.
the power that individuals like breast cancer survivors have when they come up and tell their stories. So Bridget Pargulski was one of the
Yes.
Army of Pink, and there are many others. And as you noted, breast mammogram, screening mammograms, it's considered state of the art and standard of care to say whether the woman's breast is more dense or less dense than normal. We actually score it as A, B, C, or D. And there's evidence that women with more dense breasts, that the mammograms aren't as reliable at detecting a small abnormality, and perhaps additional imaging may be a benefit. But for years, women never knew whether their breasts were dense or not because it wasn't required to be in the mammogram report. And even though the American College of Radiology said that it should be, it wasn't absolutely mandated. So part of the law that you're going to be talking about really mandated not only that it was in the report, but that women were notified of their breast density so that they could then make the determination whether additional tests could be done. Sorry to jump in on you, but let's go back to your story and how Bridget and the Army of Pink influenced the healthcare policy process.
Yes, they did. They influenced greatly. Bridget talked to us individually. She talked to both Democrats and Republicans. She just felt that it was a nonpartisan issue. She really felt that everybody should be concerned about it. And along with several other women who then joined in and would get our attention. But it took Bridget almost 3 years, 2 or 3 years, to really get this through. We'd get it started in a subcommittee, we'd pass it through, we'd get it through the Senate, and then the House wouldn't pick it up. Or and then we'd start the next year, we'd do the same thing, and we'd get it to a subcommittee or almost onto the floor of the House, and we didn't get momentum behind it. So I think the stick-to-itiveness of the women who were with Bridget and the whole group, it proved to be successful because they did not give up. There was also an issue around, the payment of it. And Doctor, you are exactly right. Many of us are always in favor of the policy, but some of us feel that, that the price tag may not be right at the right time or the right place. I'm not one of those people. I'm thinking, let's do it. If it's going to save a life, if it's going to reduce costs down the road, let's do it now. Let's not wait until it's stage 4 and someone is hospitalized for prolonged periods of time and is suffering. So let's try to spend money now, or do those kinds of exams now when it really makes a difference. So that was Bridget's story, and I'm sure she can probably tell it better than I can, but it left a big impression on a lot of us. And it was a good example of how someone who maybe feels like they failed that first time trying to get policy through comes back and tries it again, and then finds out, who the partners in this policy are and how to, work the partners and how to get Democrats and Republicans to talk together about it. And so she became a master of it after a while, because she saw every single scenario around trying to move that policy. So that's just one example. Then the other examples are certainly the kinds of things that you're talking about: tobacco, vaping, the age of smoking, all of that. So many people who are with the Action Network come to us prior to the legislative session and say, these are the things we're most concerned about. And what I appreciate about the Action Network is you really concentrate on one or two issues. You don't try to solve 10 issues at a time. One or two issues, and then you can really get your advocates involved in those one or two issues. You're very good about communicating those issues too, being able to break that issue down in one or two bullet points to say, here's what's necessary, here's the problem, here's what's necessary to fix it, and here's what we'd like you to do as a legislator. And those are really the three pieces to it. And if you can do that and be successful at it, as the Action Network has been, then you can get policy through. And as you know, Doctor, you've tried many times to get some policy through, and it is, again, just coming back, and maybe it's not the right year. Maybe the next year when there's more money in the budget, or the next year, maybe when there's another person who is the chair of the committee and is more receptive to, that policy, or putting that policy in front of the rest of the chamber, the Senate chamber or the House chamber. So it relies on a lot of different things, and to be able to read those nuances are very important.
Yes. Never give up. I mean, sometimes you can not even get to the vote for years, and then all of a sudden the next year it passes unanimously. And some things need to percolate a bit. Some things people need to hear it more than once before the idea actually comes to fruition. I might be wrong about the year. So I know you came into the Senate in 2011. Were you in the Senate when the expansion of Medicaid passed?
I was.
Yeah.
And that was really, that was really a time where we were arguing, most of all, with the governor. And there were a lot of, and it was Governor Branstad at the time, there were a lot of groups, so hospitals, physicians, individually and in groups, women, DHS, related families were coming to the Capitol and advocating for expanded Medicaid. And the governor wasn't too sure that he wanted to do that, because his argument was this: if we expand Medicaid and maybe 2 or 3 years down the road, the federal government decides not to pay, I will be able to afford it. So that was the premise, his premise. So Amanda Reagan and Linda Upmeyer actually were the two people, after all of these arguments, that got together in an office and just talked one-on-one with each other about how they were going to get this done. And they did it. They struck an agreement, and it was good all the way around. And expanded Medicaid has been a great success. So we have a lot of credit is due to the advocates who, again, stuck to it, and that they convinced all of us, certainly, and that Senator Reagan and Representative Upmeyer were able to extend the olive branch to each other and find a solution to that loggerjam and move that bill ahead.
Yes, yes, and it did, as you said, it did require some cooperation, and I think I found my advocacy voice around that issue because ultimately it came down to human dignity and social justice, and it doesn't matter how good cancer care is in general, if you don't have access to it, then you don't get the screenings, you don't find the cancer early, and you find the cancer at a later stage. So it was a huge advancement in cancer control to have access. Another big shout out to American Cancer Society Cancer Action Network. They have advanced this whole concept of bringing cancer survivors and caregivers and those who care about it into the arena to help advocate for public policy. And as you pointed out, that can make a huge difference in how the legislation moves through.
Oh, yes, absolutely, it does. And in that case, now it continues that we added 150,000 people approximately onto the Medicaid system, and it was just huge for health. It was a huge healthcare solution, and we were able to, as you have said, it is a social issue. You know, when we talk about the social determinants of health, you know, and how couch surfing for kids, you know, can lead to them not, you know, getting their insulin injections, or it contributes to some of their mental health, or absenteeism at school, and it affects their education. And so there are a lot of different things that expanded Medicaid helped do for a lot of families. And it even, there were programs that even have stemmed out of Medicaid, such as pediatric integrated health homes or health homes in general. And now those are paid for. And that health home is such a great progress toward holistic health for families. And that includes, again, you know, breast cancer exams and cervical exams. So we're very proud of the achievement of expanding Medicaid, and it's worked well for the state of Iowa. Now I know that some other states are considering it. So hopefully we'll get, you know, all 50 states involved in that.
Yes, and when we talk with Ashley of the Iowa Department of Public Health, we're going to talk about how the expansion of Medicaid actually also expanded the breast cancer and cervical cancer treatment program that Iowa has. Senator, before we let you go, any final words of wisdom to those watching? And our audience is a lot of cancer survivors and family members of individuals who've had cancer.
Mm-hmm. Just never give up. When you're talking to your state legislator, it's so important that you tell your personal story, because otherwise, you know, they may not have been touched by cancer in any way, or by someone who has breast cancer. I just walked in the Especially for You race against breast cancer at Mercy Medical here in Cedar Rapids last weekend. 13,000 people. It was, our t-shirts were blue this year instead of pink. And it was a sea of blue. And it was a beautiful thing to see. And as a legislator, you know, I'm thinking, look at how many people that we can affect by good legislation, you know, and making sure that people are getting their exams and that it's paid for, and that, you know, that the care is there and the resources are there. So it was very moving. It was very moving.
Excellent. Senator, before you sign off, one of our live studio audience members has a question for you.
Okay.
For those who don't want to give up, first of all, it took Bridget and us 5 years to get the vote passed.
So,
And I have a second question as for the deep governance.
let me repeat the question. So, Poon, who is asking the question, was actually part of the Army of Pink as well, and pointed out that it took 5 years for the Army of Pink to get the breast density legislation passed. Poon has a question about reimbursement or insurance coverage of lymphedema garments. So some women who undergo cancer treatment for breast cancer and have lymph nodes removed have lymphedema, and getting the sleeves and the different garments that help treat lymphedema can be expensive and often is not covered by insurance. Any thoughts or comments about that, Senator Mathis?
Well, I would say that if we need to get that covered, then that's something that you should come and talk to me about, because we could do a bill not only with that, but maybe some other issues surrounding breast cancer exams or necessary medical supplies that you might need. So I would say, let's start the discussion, because, legislators don't know this until you tell us. And so I'd say give me a call, and we'll talk about it.
Excellent. And your email and your office phone, people can find that on the web and your website for the Iowa Senate, correct?
Yes, just all you have to do is Google Iowa legislature, and you'll see the state capitol on the icon that comes up, and then you'll see these tabs, and there's a tab that says legislators. So click on that. It'll give you House and Senate. You can choose Senate, and then find me there, and then click on my name, and there's my number and my address and my email, and we can set up a meeting.
Excellent. Senator, thank you so much for your 10 years of public service. Thanks for being such a huge advocate for public policy to help reduce the burden of cancer. And we really appreciate the time you've taken to be with us tonight.
Thank you, Dr. Deming. Thank you for the opportunity to talk to everyone.
Thank you. Bye-bye, Senator.
Bye.
And so next we're going to bring on Ashley Ezzio from the Iowa Department of Public Health. And welcome, Ashley.
Hi.
And so thank you for waiting in the wings. We're going to shift a little bit, and we're going to talk about two programs in the state of Iowa. We're going to talk about the breast and cervical cancer early detection program, and then we're also going to talk about the breast and cervical cancer treatment program. So let me turn it over to you and give us a bit of an introduction of those programs, and then we'll get into a conversation about how they work.
Absolutely. Well, as you mentioned before, the National Breast and Cervical Cancer Early Detection Program, really long name, is celebrating 30 years. And so we're really excited about that. To give you a little background on the national program, it was established in 1990, and it basically gave the Centers for Disease Control the permission to institute this program. And they really came out with the goal to decrease breast and cervical cancer incidence, morbidity, and mortality rates. Now, this was specifically focused on underserved populations and those who may have an increased risk of developing cancer due to health disparities. So currently, 30 years later, there are programs in all 50 states, the District of Columbia, 13 tribes, and 6 U.S. territories. So it's a very wide program. Here in Iowa, what we call the Iowa Breast and Cervical Cancer Program it was implemented in 1995. So we've been around for a while.
Great. And that program in Iowa also goes by another name, correct?
Yes. So the Iowa Breast and Cervical Cancer Early Detection Program does a lot of things to promote cancer, early detection of cancer and prevention of cancer. But the largest piece of work is our screening program, and that is known as Care for Yourself. So the Care for Yourself program provides life-saving breast, cervical cancer screening programs and patient navigation services to help people get through the system. So some of those services include a clinical breast exam, mammogram, PAPs, pelvic exams, and then diagnostics. Senator Mathis was talking about dense breast tissue. You know that sometimes an MRI is required. Our program covers that for individuals who may have dense breast tissue or need it for other diagnostic purposes too.
And as you pointed out, that this program, the National Breast and Cervix Cancer Early Detection Program, was a piece of national legislation. And correct me if I'm wrong, but it had then the CDC being the sort of funder of the program, and in the state of Iowa, the CDC, which is the Center for Disease Control. Then it passes the funds down to the state, and the Iowa Department of Public Health actually administers the program, correct?
Correct. And we
Yes.
take it even a step further for local communities too. So the Iowa Department of Public Health, we partner with 22 local programs. That's where we kind of get our local connection. So an individual who enrolls in our program really has someone who knows the community, and when they have barriers or issues, can address those at a local level. So some of those are located in local public health. They may be in a clinical setting or maybe in a community-based setting.
And the program got started because there are vulnerable populations and individuals who don't have just full insurance coverage, especially 30 years ago. And it was always intended to help those that might not otherwise get the care. So in many ways, it represents part of our safety net of services for those individuals who may be uninsured or underinsured, correct?
Absolutely. That's exactly what the program's designed for. So individuals, if they're thinking, do I qualify? It really is no insurance, underinsured, so maybe really high deductible insurance that just makes some of these procedures too expensive. We do have income requirements. It's 250% of the federal poverty line, which I think is kind of an arbitrary number. So to give you an idea, a family of four can make about $5,500 a month. An individual can make up to $2,600 a month and still qualify for the program.
Right. And so before the Affordable Care Act, some screening tests could have high copays and deductibles, but after the Affordable Care Act, that was no longer allowed. So individuals that were fully insured probably didn't need the breast cancer and cervix cancer early detection program. Those who are uninsured or underinsured, how do they find out that they may be eligible? Because one of the big problems is if you don't know that you're going to be covered, you don't go in for screening necessarily. So what's the process by which the Iowa Department of Public Health makes physicians, nurses, healthcare workers, and the population as a whole knowledgeable about the program?
I think that's a great point because you're exactly right. If people don't know this is available, it's difficult to access. So I think we have some great partners. I mentioned our 22 local programs. So we provide technical assistance and funding to make sure they're doing outreach to their communities, whether that is going into community organizations and just making sure there's materials in multiple languages so people can access that. Building relationships with providers is also a huge way that we reach people through just their networks. We have over 1,200 enrolled healthcare facilities. That includes clinics, hospitals, radiology, and laboratories that provide services for the program. So we try to make sure that individuals, when they do enter care, can choose the physician that feels most comfortable for them. We also have some really great partnerships with One Iowa, who helps us reach our LGBTQ plus populations and make sure they have inclusive care. We also do some partnerships with Proteus, who serves migrant seasonal farm workers, to make sure they know about the program and that they can access services through that. So it's a lot of boots on the ground outreach, talking to your communities, and making sure people have access.
And it used to be when it was just the breast and cervix cancer early detection program that we ran into the little bit of a conundrum when you would have funding to be able to make the diagnosis. So now you've done the screening, you made the diagnosis of cancer. Well, guess what? cancer treatment needs to be done, and that is very expensive. So talk to us a little bit about how the program, or how a complementary program came into being, the breast and cervix cancer treatment program, to help with the actual funding of the treatment.
Yeah. So the Breast and Cervical Cancer Treatment Act basically took Medicaid and expanded that. So I mentioned our income guidelines for the Care for Yourself program. That's 250% of the federal poverty line. Through the Treatment Act, we're able to extend that to individuals who are diagnosed with breast or cervical cancer, or pre-cancer for cervical cancer. We're able to expand that income so that they can enroll in Medicaid and get the treatment and the services they need. Before, it would have been 138% of the federal poverty line. So we really expand that so individuals who may not have that creditable coverage are able to enter and get the treatment they need.
Excellent. So as you probably heard when Senator Mathis and I were talking, when the Medicaid expansion took place and came into Iowa, it obviously brought many individuals who were uninsured or underinsured into the program, so that they did have insurance. And I hear what you're saying is that the Breast and Cervix Cancer Treatment Act allows for further expansion of Medicaid for those women up to 250% of the poverty level, to actually be able to come into Medicaid to have their cancer treated through the Medicaid program in the state of Iowa.
Correct. And it used to be that they had to be screened through our program, the Care for Yourself program. Now that is open. So federally qualified health centers, community health centers, nonprofit agencies, just about any center in Iowa that cares for cancer patients, if they were screened through there, they still qualify for our program.
Yes. And do you have any statistics on, in the state of Iowa, for a particular year, or since the founding of the program, how many women have been screened for breast and cervix cancer, and how many women have received treatment for breast or cervix cancer through the Breast and Cervix Cancer Treatment Act?
Yeah, we actually just last year, so our fiscal year runs kind of June to June, so want to make that clear. But we did last year, we served over 2,300 individuals through the Care for Yourself program, which we were really proud of, especially with COVID having restrictions. And I think there was just general fear about engaging in some of those prevention activities. So 2,300 individuals took advantage of the program. Of those individuals, we provided 1,800 clinical breast exams. There were 2,100 mammograms provided and over 800 Pap tests. And of those individuals, we did have some cancer diagnosis. So last year, 38 individuals were diagnosed with cancer that were screened through our program. The year before that, there were 27. So still low numbers, but we're catching cancer, we're catching it early, and our local coordinators are able to really connect that individual with their local cancer center, identify barriers, get them into care, and get them with amazing doctors such as you.
And as you pointed out, this is really a matter of funding, not creating a separate medical system. The early detection is done at cancer centers that are certified for doing that, and the treatment is done at cancer centers in the state. This is really the state helping to create awareness to women that they need to be screened, the value of screening, and then allowing for funding so that they can get their screening and then ultimately their treatment.
Absolutely. So there's a lot of the funding that we have from the Centers for Disease Control really does allow us to serve more individuals. We're hopeful to serve more. We want to grow the program. We want to serve our communities where they are and where it's needed.
Senator Mathis used a term, social determinants of health, and I know, Ashley, you're aware of what that is. And one of the reasons that that the federal government set up the legislation, CDC is doing the program, and the state of Iowa has expanded with the treatment, is that we know that those individuals who are uninsured or underinsured not only have difficulty paying for those, but they have a higher risk of developing cancer. Those vulnerable populations have a higher risk of developing almost every type of disease, but cancer is one of those, and it occurs in a much greater proportion of the population of the underserved than it does those who have insurance. So it's sort of a double whammy. Not only can you not afford it, but you're more likely to get it.
Absolutely. And that's where we want to make sure that individuals have that culturally appropriate connection to healthcare facilities. And that's where our local coordinators are sometimes called community health workers. So they bring the knowledge and expertise, whether that's just knowing how far it is that you need to travel to your appointment, or perhaps it's a language you speak, or someone that knows this is the health insurance you have and this is what's covered. So we really do want to highlight that. We want to reach individuals who are at a higher risk. We want to provide the education and the support needed to get them into treatment and care and screening.
Great. Ashley, let's get down to the nuts and bolts. And so let's create a scenario here where a woman who is uninsured or underinsured detects an abnormality in her breast, feels something's not right, hopes it goes away because she doesn't have insurance, or she doesn't know if she has insurance, not sure whether it's covered, and eventually she seeks medical attention and needs to have a diagnosis. Let's say she shows up at a clinic without any insurance and without the ability to pay. How can that center access your program on behalf of the patient to get her enrolled? And right now, let's say we're talking about the screening, the early detection program.
That's a great question, because that's really where we want to create a streamlined process so that when individuals do show up with no prior notice, that we can make those connections and get them enrolled in the program. So I would say in this situation, it would be great, whether this is a physician, a nurse, a biller, your front desk staff, whoever that is in that clinical setting that's kind of responsible for knowing the payment side of how this client will go through. We would want them just to simply call. If you don't know your local program, give us a call. Our number is pretty easy, and I'm sure we can link it in this conversation, but it's 1-866-339-7909. That gets you right to us. We'll make sure to connect you via email or phone to that local coordinator there. And then it's simply a consent and enrollment process that can be done over the phone. So it's very simple for clients to enroll. We go through qualification right then and there. And hopefully the more you work with the program, the more staff in the clinic knows, okay, this is a care for yourself client. Let's go ahead and let's talk and let's get this done.
And approximately how long does it take from the time I call you until the patient is enrolled?
It can be as long as we can verify just the age, income, that can be less than 5 minutes. I mean, it's very fast, very quick. We can do consents over the phone and enrollment over the phone, make sure the client understands what the program is and what it can do.
Great. So we do the screening and it's not cancer and it's high fives all around and we celebrate. If the screening is done and the diagnosis of cancer is made, then that's a huge burden of fear and stress on the patient. Now, the screening has been done, which arguably is the least expensive part of the cancer journey. Now we're facing treatment, which could be surgery, chemotherapy, radiation therapy. How do we then move from the breast and cervix cancer early detection program to the breast cancer and cervix cancer treatment program?
So we have very specific individuals who do the breast and cervical cancer treatment enrollment. I am one of them. And so that same phone number would be a simple phone call. The center can provide and do a Medicaid application right then and there so that we can then have the conversation, get the needed paperwork that's required, and go ahead and get an application submitted. Then we would work with the clinic to make sure that they have the insurance information, that the client has the information they need to provide to all of their specialists and appointments. So we try to make it easy and as streamlined as possible. And working with healthcare clinics and the client together really makes that process easier so that we can communicate dates, treatment, how that needs to go forward.
And as you know, that is really a stressful time in a person's life when they've just been told they have cancer. Although a delay of a few days or even a week or so is probably not going to affect the outcome, it's a huge burden in terms of stress and fear. So how long does it take on average from the time someone requests to be evaluated for the breast and cervix cancer treatment program until they have been assured that they can be covered and proceed on with their treatment?
So that kind of depends on how quickly we need to get things moving. There is something called presumptive eligibility for Medicaid, where when we need to get someone enrolled and we need them to get care right away, we can do that within a day or two. That is a very simple application that we can just start the process and say, okay, we're going to get coverage for a short period of time until we can make sure that your full Medicaid application goes through. So we can be very fast about it. And getting those decisions for presumptive eligibility is almost instant. So as soon as we run that,
Yeah.
we can determine it.
Yeah, that's a wonderful aspect of the program. That must be very gratifying for you and for your fellow workers in the Iowa Department of Public Health to be able to provide that sort of service.
Absolutely. I think we always at IDPH, we may not get a lot of face-to-face interaction with our clients because our local coordinators are doing so much. But every once in a while, we'll get a thank you note from someone. And that really does mean the world. It's a privilege to walk with someone through this, as I'm sure you know, and to be a part of their journey, especially something like a cancer diagnosis or even just an uncomfortable exam like a mammogram. So the easier and less stressful we can make that, the better we feel about our job and what we're doing.
You know, part of this conversation tonight is about advocacy. So, Ashley, I don't know if you know, but I was at the federal Capitol last week with the American Cancer Society Cancer Action Network Lobby Days. This year it was virtual, but we met with our 2 senators and our 4 representatives, and we were citizen lobbying for 3 things. And the first was to increase funding at the federal level of the NIH, the National Institutes of Health, the NCI, the National Cancer Institute, and the CDC, the Center for Disease Control. And specifically as part of the CDC budget, we were advocating for an increase for $275 million to go to the National Breast and Cervix Cancer Early Detection Program. So that was one of our asks. And so we had cancer survivors from every one of the legislative districts throughout the country asking for that increased funding. And this year we specifically called out the Breast and Cervix Cancer Education Program, Early Detection Program, excuse me.
It's a mouthful, isn't it, that name?
Yeah, it is.
Absolutely. We are, I'm so glad that you see the value in this program because I really do think that it saves lives. And to the cancer survivors and advocates sharing their story, that is so impactful and I think can make a huge difference in someone choosing to get screened or not get screened. And so we really appreciate all of the support and utilization of programs like these.
When Iowa Department of Public Health seeks, I don't know if the word grant or the funding from the Center for Disease Control. Is there any role that we as doctors and breast and cervix cancer patients can play in the process or the extent of the funding that happens? Is that a formula that's pretty well set in stone, or is it something that can be affected by advocacy on the part of those of us in healthcare and cancer survivors and their families?
I absolutely think you can have an impact. I think the number one thing is making referrals to the program, especially as healthcare providers. I mentioned, I know it takes a team in that healthcare office to really get to know the ins and outs of what everyone needs. And so if you are in healthcare, I encourage you to learn more about this program. Connect with me, connect with my team. Let's talk about it so that you understand it and can make referrals. That way we can make sure we can serve your clients. If you're a community member, I think that your recommendation and impact has just as much value. Someone you love needs to hear that you care that they get screened for cancer, and that cost should never be an issue. Check out our website, get in contact with us. Let's make connections and referrals to really take advantage of this program. And I think as the Department of Public Health and as this program, goes into next year, we'll be writing a competitive application. We need the input of the community and just the support and to know what's needed in cancer prevention and care.
Yes, and I would imagine it's one of those things that if we weren't doing many screenings or funding much cancer treatment in the next year, it would make it difficult to go to the CDC and say we need more.
Exactly.
And
And yeah.
Yeah, it's one of those that we really want everyone to know about the program and to utilize it fully, because not only will it save lives, but it will ensure adequate funding the next year as we continue to try to grow the program and make sure that everyone in Iowa who's eligible can have access to breast and cervix cancer screening and treatment.
Absolutely. And one point I just want to make sure that I don't leave without mentioning is that we did expand our program to make sure we can provide patient navigation only services. So this may be someone who's fully insured, but really needs help to find that provider, or they've got transportation issues or translation services are needed. Our program can also provide that. So I just want to make sure we mentioned that perhaps a Medicaid member needs some assistance. Our program is designed to provide that very intense support as well.
Excellent. Thank you for pointing that out. And are the navigators employees of the Iowa Department of Public Health, or if someone calls and said, I really need a navigator to help me through this, do you assign them a navigator in the community, or is it an Iowa Department of Public Health employee?
As much as they would like we actually use our local program coordinators. So that would be one of those 22 local program patient navigators that would take on their care and make sure that they got navigated through the process.
Great. And just to make sure I understand correctly, that is provided free of charge. And even if you end up not being eligible for the screening dollars or treatment dollars, you are willing to provide the navigator service free of charge?
Absolutely. So if they qualify income-wise, but they have full coverage insurance. So we don't need to pick up the bill for any clinical services, but we need that help navigating. We absolutely provide free patient navigation only services.
Okay, excellent. Anything else? Any other words of wisdom? Anything else you want to tell us to help promote your program, which is just wonderful?
Well, happy Breast Cancer Awareness Month. It's October. I'm just very grateful that you invited the program to this platform. Thank you to all the healthcare providers for all you're doing. This is tiring work. And Dr. Deming, thanks for having me on today.
You are welcome. And I'm wearing pink tonight. So I'm part of the American Cancer Society Real Men Wear Pink I'm committed to wearing something pink every day in October. October is Breast Cancer Awareness Month. So thank you so much, Ashley, for being part of our program. Before you leave, any questions from our live studio audience? I don't see any right now. You've answered a lot of my questions. This has been very informative, educational to me as well, and we will definitely promulgate that number and make sure that every woman who needs your services gets them.
Thank you
So
so much.
thank you, Ashley, and thank you to our live stream audience for attending tonight. Just to remind you that if you want to watch this again, or if you have friends or acquaintances that might not have been able to watch this live tonight, this recording, our video podcast, will be available on the MercyOne Cancer Center website and also on the Above and Beyond Cancer YouTube channel. Again, this is Dick Deming, Medical Director, MercyOne Cancer Center and founder of Above and Beyond Cancer. Thank you for joining us this evening. See you next week.